Hello, everybody, and a very warm welcome to this third webinar in our series in November from the Royal College of Psychiatrists Old Age Faculty on the topic of new disease-modifying therapies for Alzheimer's disease. The previous ones have been very well attended, and today is no exception. So thank you very much for taking the time. I think you'll find it worthwhile. We've got two completely fabulous talks today on very, very important topics, most notably ARIA, which is, of course, a significant side effect of these medicines, but also a talk about the practical use from one of us, an old age psychiatrist who's actually used them in patients. So we'll have two talks followed by 10 minutes of Q&A. If I can encourage you to use the chat function for questions, that would be really helpful. We'll try and answer as many as we can on air, and we'll also answer those in the chat function as well. Please try and ensure that your cameras and microphones are switched off. And that's particularly important because this will be recorded and will be available publicly on the faculty website. It's important to know that the faculty may have organised this, but the speakers are expressing their own personal views, and it's not a position endorsed necessarily or indeed at all by the college. It's important also that people don't share slides from the speakers without permission. Much as we would like to go on, we will finish promptly at 5.
We've given that, well, what's the name give her that depot? You have to put on so she's screaming out. Yeah. So she's been.
Hello, can people hear me?
Yes, Ben, we can, thank you.
Yes,
thank
we
you, Bob.
can.
Did you get the first part of what I was saying there?
We did.
We did, fantastic. So I think we can, sorry, someone I think just unmuted, so let's be careful about that. So I probably failed to introduce myself. So my name is Ben Underwood. I'm a consultant old age psychiatrist working in Cambridge. And if you look at my background, you can see that actually today I'm in one of the colleges, and this is the room they've generously given me for this purpose. I have a number of declarations of interest. This is a sensitive topic, and it's really important that we make those clear. But I'm not going to read them all out. They're there on the screen for people to see and are being recorded, so you can look again later on. So I am now going to hand over to my colleague Vivek Patan, who is going to introduce himself and also our first speaker to talk about ARIA. Vivek, it's all yours.
Good afternoon, everybody. So I'm Dr. Patton. I'm a consultant old age psychiatrist based in NHS Forth Valley in Scotland. I'm the current chair for old age psychiatry faculty in Scotland, and in my other role, I also work as a national clinical lead for dementia with healthcare improvement in Scotland. So without much ado, so I would like to introduce Professor Kevin Bradley, who is the director of PET network. He's a neuroradiologist and also a nuclear physicist, and I had the opportunity to talk to him before, and it's a fascinating talk, and pleasure to welcome you.
Vivek, thank you very much. I hope everyone can hear me. If one of the chairs could just confirm.
Yep, we can hear you and see you.
Perfect. So I'm Kevin Bradley, and I've been asked to discuss the interpretation and accessing of amyloid PET scans. I am not strictly a neuroradiologist. I'm actually a radiologist and a nuclear medicine physician, specialise in PET CT and research of PET CT. Now, I think I've no conflicts of interests, but I am the chairman of something called ARSAC, which is the licensing authority, and a license is required for the administration of any radioactivity to a human subject in the UK, and also for the institutions where that administration takes part. And that is relevant to the talk, and maybe why Bob and Chinese invited me. I also audit outsourced NHS PET CT scans in England. I was asked to do that by the Department of Health many years ago, and I've done so ever since. So today, I thought I would briefly run through what a PET CT scan is, a few of the legal requirements, and I can't help myself, but I want to show you some FDG scans because I believe that's very important in the setting of dementia and brain imaging. I'll then talk about the amyloid tracers, show you a couple of scans just, and then hopefully have a discussion on commissioning, and I'll leave plenty of time for questions, which I think are going to come together at the end after Brady's talk. So in brief, the patient journey, well, the patient requires a referral, which will be your job, and that must be to a licensed centre, and that's licensed, as I say, by ARSAC, and he needs 2 licenses, so 2 green lights, if you like, both for the employer and the practitioner. And I don't think that's your concern, that's the concern for someone like me. The request, because it involves ionising radiation, because a PET scan and indeed a CT scan both involve ionising radiation, must be authorised by an approved person, and then an appointment will be issued. The patient, for FDG scans, you may be aware that they need to be starved overnight with water only on the day of the scan, or certainly within 6 hours of the scan. The amyloid PET tracers require no special preparation whatsoever. So what is required for the scan is an intravenous injection. Now that is radioactive, so there are consequences. The key one, though, is that the patient must not be incontinent, because if they're incontinent, they become a radioactive hazard. And that's, I'm afraid, a real management issue. So no incontinence, please. The tracer is administered into the blood. At that point, we want to wait until we get the ideal signal to noise, because at first, obviously, it's in the bloodstream. It then has specific uptake, and there's non-specific activity in the background, and there's an optimum balance between the two. And that's different for the different PET tracers. I'll demonstrate that later. The scan takes around 10 minutes, maybe 15 minutes on older scanners, and the subject must stay still for the entire scan. And then obviously someone like me issues the report. This is taken exactly out of the ARSAC notes for guidance. It's about a 94-page document, which in part I'm responsible for. And I'm not going to read this out to you, but this is ARSAC's attempt to make sure that the quality of any cerebral amyloid service and report is of a good quality. So the people providing this service must be part of a relevant MDT and have interactions with your good selves. And obviously they need to be well trained. First and foremost, though, for FDG scanning in dementia, so that they're broadly trained, and then have specific training with reference to cerebral amyloid. And if you see at the bottom, the suggestion is for a minimum of 50 cases. This is what a PET-CT scanner looks like. This is actually the new scanner in Cardiff. It was installed in July of this year. If you look at the very front of the scanner, it is just like a CT scanner, but then there's greater depth to the scanner, and that's the PET component behind it. This particular model is 32 centimeters long. The PET component, which is very good, that's longer than most PET scanners, and is probably the way scanners are going in the future. It's been modelled by one of our radiographers. He has given his consent. He's in an oncology position with his arms up. Patients for cerebral amyloid will have their arms down in a comfortable position. They may or may not like to have a head holder. Some patients don't like it. The scanner is essentially pretty quiet. It has to run a little air conditioning unit, but it is pretty quiet. It is not like MRI, and it is better tolerated than MRI. So first of all, very quickly, some Alzheimer's cases. I'm afraid with the projection that we have this evening or this afternoon, that my mouse is disabled. So if you look at the right-hand image there, that's an axial image through the brain using FDG, which is a glucose analog, and just shows you cerebral metabolism. And if you're at about 5 o'clock on your screen, you can see that there's relative hypometabolism posteriorly. In fact, there is also on the right side of the head, which is the left side of your screen of that image. So bilateral posterior temporoparietal hypometabolism, and that's the hallmark of Alzheimer's pathology. And we can have a little computer that finds where there's hypometabolism. Interestingly, it's not sensitive enough to detect the abnormality on the right, only within the left cerebral hemisphere. So another case, very quickly, you can read the clinical details, but the thought process was that this was likely to be frontotemporal dementia. if you're good at your CT and you look at the right-hand image, you can see that the right medial temporal lobe is clearly very atrophic. And I think one would be certainly thinking perhaps Alzheimer's on that. But here's the FDG PET scan, markedly abnormal, severe defects in the right cerebral hemisphere, moderate defect in the left. That's Alzheimer's. So another case, very similar. If you look at that CT, actually it's the temporal pole on the right is very atrophic. This was actually reported as normal by a neuroradiologist. This scan, the image on the left tells you where the sagittal image has been taken through. I'm afraid the front of the brain is to the right of your screen, which is unusual, but it was a necessity for this, and it shows frontal hypometabolism. This scan, if you look at the three images across the middle of the screen, where the temporal lobe should dangle down either side, they're actually
Kevin, you've muted yourself.
Muted. You need to put it back to the presentation mode, I think.
Yeah, I will. Sorry.
Okay, thanks.
How much did you hear?
The last slide, I would think, probably with the multiple images.
Okay, that one. Fine. So that's, I was just FDG. So that's just a nice intro. So we need to really do the meat of the study here. And these are important.
Still, it's not in the presentation mode. You need to go to the presentation.
Mine is. I do apologize. Mine is in present. It is now in presentation mode. Can you see the Brack staging?
I mean, we are seeing it. I don't know. Can everybody else see
Vivek,
it?
it's in presentation mode for me.
Okay,
And I think everyone else. So
Yeah.
you're good to go, Kevin.
Yeah.
Oh, sorry. Okay. Well, Brack and Brack were two really excellent German pathologists ages ago who were very fastidious, and they did the Brack staging for both cerebral amyloid and cerebral tau. And they took a huge series of basically randomly selected post-mortem studies, so all pathologies, and they just looked for cerebral amyloid, cerebral tau, and they divide this staging of both, and they're essentially similar. So one starts off with no pathology, that's fine, and you can see the age spread on the graph on the left. And then as all of us, as society ages, one is more likely to find cerebral amyloid, and it starts in the entorhinal cortex, which is the medial aspect of the medial temporal lobes, and then spreads to the medial temporal lobe through Brack stages 3 and 4, which is the limbic stage, and then finally to the neocortical stage. And this takes, it appears, because they've got excellent numbers, they were really excellent people, many, many years. So we should have a window in order to measure cerebral amyloid in the brain. So then a chap called Bill Clunk came along, and this is from his seminal article, for which I think he received $1 million from the Alzheimer's Society. And if we start at the top, he invented something called PIB, but that was carbon 11 labeled. And carbon 11's only got a 20-minute half-life, and it is not convenient and is not really suitable for mass use, but it was a wonderful research tool. And the PIB essentially was a little bit like Congo red, you know, a histology stain that one uses to see amyloid on histology slides. But instead of that, he managed to attach a little radioactive molecule, carbon 11. Latterly, we now have fluorine 18, which is much more useful to us. But carbon 11 is PIB, if you hear people talking about PIB. And he got these excellent images, and control subjects had very little PIB uptake, and subjects who had advanced what was thought to be Alzheimer's disease, and in fact we now subsequently know from post-mortem validation he was correct, had a lot of uptake of this tracer. This is another one of his images, and we've compared it to, sorry, on the last slide I should say, there was an abnormal FDG scan which was used as a degree of validation as well as clinically. And here they showed Alzheimer's disease had a lot of uptake, and this was on a semi-quantitative scale, so these are like-for-like comparisons. But carbon-11 is just not convenient. So GE basically bought the rights and they invented flutometamol. I will say that flutometamol and all the F18 label tracers, and they're all very, very similar, despite what this slide seems to show, but they visually appear similar, have a lot of non-specific white matter uptake that the original PIB did not. And I think that led to a delay in getting these, well, certainly flutometamol to market. They were the first. Both the manufacturers of flurbetapir and florbetabend didn't really care. They just went straight to market. Whereas I think GE were being cautious. Nevertheless, you can see that the tracers have a different ED is estimated dose, by the way, and I've got the UK dose underneath. So these give you 2 to 3 times annual background radiation in the UK. We do not regard, these would be sort of a medium dose procedure. But they have different uptake times. So the uptake time is the time between the intravenous injection and the scan. There we go. This is what a normal looks like. This is a just offline midline sagittal. And if you look towards the noses at the left side of your screens to the right, if you know where the cerebellum is, the cerebellar grey matter at its periphery has very little uptake. And then you realize that the brain just looks a little bit spiculate. This makes it a lot more easy. By the way, this is a recent scan only from a few weeks ago on our new super duper scanner. But you can see this is a relatively young person. They've got good brain volume on the CT, which is the middle image. And on the left, one can imagine you're looking at a white matter tract surrounded by grey matter with a lot less uptake. And that's fundamentally how to interpret a normal, i.e. negative scan for cerebral amyloid, is that one can see good differentiation between the non-specific uptake in the white matter and what is meant to be specific uptake is less in the overlying grey matter. And I've got a fused image on the right. This is all the same image, just displayed in different ways. The manufacturers, they're very dogmatic about how one should interpret their scans. The reason for this is because of how they went to the FDA in order to get licensing. In fact, having fused images, as on the right-hand set, where one can see where the brain is relative to where the, if you like, functional uptake of the amyloid tracer is, are very, very useful. I think are obligatory, but that is not actually what the FDA approved. So this is quite high, high axial slice in the brain. And a lot of my colleagues say, oh, amyloid scans, very easy to interpret. Well, I've done a lot, and I think that most of them are straightforward, but that actually in elderly people, if they've got cerebral atrophy and therefore widened sulci in their brain, can be very difficult indeed to interpret. Younger people, much easier. This was a recent subject thought to have Alzheimer's, but this is a normal cerebral amyloid scan. Therefore, there is no cerebral amyloid, and that should therefore be, well, means that they do not have Alzheimer's pathology or significant Alzheimer's pathology at this time. So a slightly lower slice, I think easier here. One can see that sort of arborization, if one likes, of the white cell tracts. And this is a really easy, good quality, normal study. There are different color scales, but actually I like the black and white just to look at the PET component. And one thing I like is rather than doing black on white, is also doing the reverse, which is bottom left image, that I find very helpful too, to just reverse the color. The others are different color scales. I like those a lot less. So we've got 3 tracers. The manufacturers have produced what's called a region map. So this will, you put the PET scan that one has acquired into a standard space, applies the region map to it, and you can read out numbers, i.e. quantify the uptake. This is the flutometamol region map. I'm afraid you have to imagine lots of axial PET images under it. It doesn't project well. And one can read out, these are all zeroed because I've taken it off the region map. But the flutometamol, which is the GE product, uses the PONS as a reference region. That's rather small, but this does work and it is validated. Here's florbetapir. Florbetapir uses a wider set of regions of interest, but actually has then smaller regions that one... Hello? Hello? I hope you can still hear me. This is florbetapir.
Yeah, we can hear you.
Good. Florbetaben uses cerebellar white matter as a region of interest, which makes good sense to me, and has a lot more regions. And it's the, if you like, the latest kid on the block and is currently available in the UK. So the way we are taught to report such studies, and there are courses for erstwhile reporters, is to say negative for cerebral amyloid, that is, that the grey matter uptake is less than the white matter, or positive. Now, I have a problem with that because clearly if one can go from negative to positive, one has gone through a standard bit of radiology, which is the grey in the middle. It is surprisingly rare, but it does happen and is difficult. So the manufacturers and researchers have come up with other scales, one of which is the SUVR scale. We use SUVs a lot in PET, which is standardized uptake value, but this is a ratio. The ratio region of interest is varied between the tracers and between different researchers. I've listed a few there. The PONS makes sense. The cerebellar cortex or grey matter makes good sense to me because the amyloid does not generally exist in the cerebellum. And recently, actually Bill Klunk, the original force, if you like, behind PIB, has coined this centilloid scale, which is a 0 to a 100 scale, whereby he has, in effect, back-registered more modern tracers to the original PIB and come up with ranges that exclude plaque, which are typically less than 20, or for at least moderate plaque. No, sorry, I think it was less than 10 excluded plaque. Above 20 was moderate plaque. So again, there are grey areas. What about an abnormal? Because I've only shown you normal. This is an abnormal study. There is complete loss of grey-white matter differentiation. As you can see, I've showed you a fused image. These are all at the same level, and both white on black and black on white. So pretty straightforward. I think this instance is actually a very abnormal study. I'd almost wonder in places that the grey matter exceeds the white matter, which is relatively unusual. And that's just showing you the two scans I've already shown you side by side. And it is surprising that one seems to flip-flop between these two. Very quickly, because I realise that time is moving on. This is flutometamol. These are being performed according to research protocol, so the images do look a little bit smoothed, but one can see the cerebellum. There's no uptake peripherally within the cerebellum. And these are all very positive scans because they're in the early days of actually validating flutometamol. Here's florbetapir. They like a very soft looking CT and very soft kernel. And in fact, if one varies the PET reconstruction, one can vary the image output, which is an issue. But by and large, it is relatively binary. And very quickly, this is actually part of my research as an FDG scan, but I'm trying to produce tools that improve the image quality, in particular subject to motion. And it's surprising how much motion there can be and micromotions within PET scans. So the scan on the left, using the same data, by splitting it down rather than a 15-minute scan, went to 1 second scans that are all co-registered together. And at the bottom, it shows you the rotations and translations achieved to do that. And we have a program now that can run in about 3 to 5 seconds. One can produce the scan quality on the right. I don't yet have, because I've done, since we've had this program, very little amyloid, and it's all been, they've been good quality scans. I don't yet have an example of amyloid, but I no doubt we'll have one soon. So we're nearly done. So how to sum up? Well, cerebral amyloid is not specific for Alzheimer's disease. It's very important. This is not an Alzheimer's scan. However, the converse, the absence of cerebral amyloid does exclude Alzheimer's. I wonder if it will be required as a gateway to amyloid lowering drugs, which is, I think, why everybody is attending these sessions, you're interested in setting up perhaps such services if they're approved. I would wonder if CSF and blood biomarkers may be used as a gateway because they will be cheaper than a PET scan. But who knows, the PET scan may be used for problematic cases or actually may be found to be more patient-friendly in some instances. I would hope that blood biomarkers will improve over the next few years. I think it is interesting that with these antibody-lowering drugs, that the cerebral amyloid scans can normalize on treatment. And by normalize, I mean that the uptake, quantified uptake, falls to a level below that where the antibody-lowering drugs would be used. I don't, because of my ignorance, I apologize, know whether any blood biomarkers will be able to help with that. So who knows, we may not be a gateway to the start of drugs, but we may be actually helpful in telling you when you can stop a drug that has potential side effects, particularly as cerebral amyloid may be getting low. The PET scans are not currently commissioned. That would be commissioned by NHS England or by the 4 nations. Would there be a problem with performing these PET scans? I know some people think there will be, but I do not. There are over 100 licensed centres at the moment. Most only have 1 PET scan, PET scanner rather. Some have 2, a few have 3. I think these are quick scans. The issue will be the uptake facility. I've just been get a message that I can no longer share video. I hope you can see it. But the scans cost about £2,000. I will tell you that's broken down, that the tracer costs about £1,000. Transport of it to a scan centre, it currently is £300, which I think is scandalous. And most centres charge in the region of £700 for the scan, which actually just breaks even. I will be delighted to answer questions at the end of the presentations. This is a patient who's got active large vessel vasculitis on an FDG scan. I hope that's helpful, and I look forward to your questions later.
Thank you, Kevin. It was a very good presentation with lots of information for us. So we have got a few questions, probably 1 or 2, I think. So one of the question is about where do we access the training for use of these scanners?
You don't. The people like me should be trained, and most already are. You will not be reporting these. That would be wrong. And I will tell you, wouldn't be allowed. Okay, you're not radiologists, and you haven't got the right experience. So leave that to the people who do this for a living. I do think it would be useful, though, if you're going to start, or if you're allowed refer, and then start referring patients with these scans, go and make friends with your local radiologist and go and visit, or nuclear medicine physician, go and visit their centre and walk through as if your patient's having the scan, so you get a sense of what they'll face. I think that's very helpful. I always encourage clinicians to come and see, and it just builds liaisons and relationships, doesn't it?
Yeah. So just on that, so the radiologists, do they need special training for this? Or
yes, absolutely. And they need an RSAC license, and RSAC is quite, I am chair of it, but RSAC is quite fussy. There are hoops to jump through, but it won't be a problem.
Okay. So there are a few more questions, but I'm just taking my prerogative. So how much would it cost in a ballpark figure, I think, to set up a PET scanner?
Oh, to completely set up a PET scanner from
From scratch, yeah.
Wow. The way I would do it, £4.5 million. Okay, so the high energy radiation or radioactivity in the PET tracers, you're not going to set one up for scratch for doing cerebral amyloid scans. These will all need to be bolted onto what already exists in the cancer networks. All cancer networks use this. About 98% of PET in the UK is FDG. That's untrue now. About 95% is FDG in the setting of oncology, with PSMA for prostate cancer rising rapidly.
So there are lots of questions in the chat. So I will hand over to Ben for the next talk. But in the meantime, if you could answer the questions in the chat, which way you feel relevant, that would be good. Thank you.
I'll try.
Thank you very much, Vivek, and thank you in particular to you, Kevin, for such a fantastic and informative talk. I certainly enjoyed it and learned a lot, and I'm sure others have as well. But it's also my great pleasure now to introduce Dr. Brady McFarlane. Brady is not only a really lovely chap, but he's also one of us. He's a proper jobbing consultant old age psychiatrist. He works in the New Forest in Hampshire, but he also has a research interest. So he runs the Memory Assessment and Research Centre down there, and he is also the CRN speciality lead for dementia in Wessex. Now, in that role, he has undertaken many commercial trials of lots of different CTIMPs in both MCI and dementia, and in particular, he's been involved in trials of these monoclonal antibodies. So he's going to tell us what it's like to really use these drugs. So thank you very much indeed for joining us, Brady, and I will hand it over to you.
Thank you, Ben. Hopefully, you can see my slides. Can you give me a thumbs up, Ben?
I'll give you a thumbs up, Brady. It's good to go.
Excellent. So yeah, thank you very much for inviting me to talk. So as Ben said, my name's Brady McFarlane. I'm an old age psychiatrist working in the New Forest mainly. And I also work at a dementia research unit in Southampton. So as Ben said, I've been involved in lots of the monoclonal antibody trials, including the recent Clarity AD lecanemab trial. I'm currently giving patients both lecanemab and aducanumab, not at the same time. And I think that's why I've been asked to talk today with my very catchily titled talk that you can see there. So a quick declaration of interest. So alongside my community patch, I'm director of MARC. So this is the Memory Assessment and Research Centre in Southampton. This is my team. This is our conference in August. A reminder to everyone that there used to be short sleeves and blue skies. I also like the fact that we look like a touring cricket team. So as part of my role with MARC, I've worked on lots of different commercial trials for dementia. I've also done some consultative work for ISI, and as Ben said, I've got a role for the NHR. So my talk today is in a personal capacity. My biggest declaration is I've got a horrendous cough, which has dragged on for nearly a month. I'm blaming my kids for. I'll try and mute if I can, but it's difficult with the screen, so apologies in advance. So some of you will have heard Ross Dunn's talk, which was the last in this series a couple of weeks ago. He talked about setting up a lumbar puncture clinic in Manchester. I thought it was fantastic, really inspiring talk. I guess one of the bits I wanted to get across today was that I'm currently giving these drugs to patients in a little community hospital down in the New Forest in Lymington. And it's certainly manageable as an old age psychiatrist, albeit at the moment as part of a much wider research setting. So my talk today is based on the theme of this series of talks that the college has organised, which is looking at a hypothetical situation where the monoclonal antibodies are licensed and available. So I'm not today commenting on efficacy or a risk-benefit calculation of side effects, all of which are very valid conversations to have. So instead, what I'll talk about is something about what the side effects actually are. I'll touch on ARIA, but given my absolute lack of expertise in radiology, this will be quite superficial. I'll talk about how ARIA was monitored and managed during the studies, and I'll try and illustrate with some of that with some case studies, and hopefully end with what we'd need to do to give these drugs from a safety point of view. So this is Lymington Hospital, where patients have been having the research drugs. This is how it used to look in the 1920s and how it looks now. So it's a small community hospital with 80 to 100 beds. It's consultant-led. Although we don't have an A&E, we have got a medical admissions unit with a small resus team on hand. So for the trials, I've been using the medical day unit, and they had some experience in giving blood transfusions and some of the IV biologics, so the DMARDs, the disease-modifying rheumatoid arthritis drugs. As you'll see, I've crossed out the flippant use of the word proper doctors, as I completely agree with Ross Dunn, as what he said a fortnight ago, is that, you know, as psychiatrists, we are proper doctors and we're perfectly capable of giving these drugs and monitoring response. Probably worth noting that I was glad that there were geriatricians around with kind of more in-depth resuscitation skills in the hospital, just in case there were problems. So this is the lecanemab paper published in the New England Journal of Medicine, which came out of the Clarity AD trial. And just to put the timing of Clarity AD in context, so the kind of study results came out at the end of November 2022. England had just beaten Wales in the World Cup, 2 goals from Marcus Rashford, bish rash bosh. But despite this, lecanemab still made the Times front page with the headline, "Dementia Drug Slows Decline." Very quickly, this is the famous CDR sum of boxes graph showing change from placebo over the 18-month trial, and the much quoted 27% slowing. And the change in amyloid as measured in centiloids that we've just heard about from Professor Bradley's talk, measured by amyloid PET. And this shows exactly what was talked about the normalizing of scans on treatment. So the claim is here that the first oval on the left change had already occurred at 3 months, and by the end of the study, amyloid's been cleared to the extent that people with those levels of amyloid would not have met the inclusion criteria for the study in the first place. So with that great success at clearing amyloid comes potential side effects. And I'll move on to talking about safety and side effects now. So I'll stick with lecanemab, but side effects are actually pretty similar for other monoclonal antibody drugs used in Alzheimer's trials. So at the top, we've got the adverse events of special interest, and I'll talk about those in a second. So we've got infusion reactions and ARIA. Other side effects listed here included headaches and falls, but other things listed that were not too dissimilar from adverse events seen in the placebo arm. So ARIA. So the use of anti-amyloid beta antibodies has been associated with treatment-emergent MRI signal abnormalities, which have been called amyloid-related imaging abnormalities, or ARIA. As I said at the start, I don't really have the time or the expertise to go into the detail, but if you're interested, I've put at the bottom an article from Brain this month, which I thought was a really good overview. So it's called Amyloid-Related Abnormalities, ARIA, Radiological, Biological and Clinical Characteristics. And I thought that was very helpful. There are 2 classes of ARIA seen. So we've got ARIA-E, which is related to cerebral edema. So that involves a breakdown of the tight endothelial junctions of the blood-brain barrier and subsequent accumulation of fluid. And we've got ARIA-H, which refers to microhemorrhages or macrohemorrhages observed as hypointense hemosiderin deposition. ARIA tends to be mild to moderate radiographically, tends to be asymptomatic or mildly symptomatic clinically, and tends to be self-limited or reversible, but it can be more serious and indeed potentially fatal. So the figure on this slide and my next slide are taken from an article by Barakos and others from the Journal of Prevention of Alzheimer's Disease. So figure A on the left shows an MRI with features of parenchymal edema, so that's ARIA-E in the left parietal occipital lobe. Figure B in the solid circle shows leptomeningeal effusion, so ARIA-E in several sulci within the right temporal occipital lobe. And ARIA-H, so slide C on the left, shows microhemorrhages, so ARIA-E, based in an area of parenchymal edema, so based in ARIA-E, which is shown in the dashed circle. And slide D on the right shows superficial siderosis, a small leptomeningeal hemosiderin deposit in the left frontal lobe sulcus, which is the dotted circle. I'm sorry about this slide. So I realised at the very last minute I'd missed out mentioning anything about the incidence and symptoms of ARIA. So in summary, 21% of people on lecanemab had ARIA-H or ARIA-E on the trial. So most of this was radiological and asymptomatic, but nearly 3% of participants had symptomatic ARIA-E. So the symptoms of ARIA tend to be the kind of things that you'd imagine. So headaches, confusion, visual changes and dizziness, amongst others, but more serious ARIA side effects can be seizures, encephalopathy, focal neurological deficits. It's also worth noting here that ApoE genotype had a role in ARIA rates. So in the Clarity AD trial, the role of the rate of ARIA in ApoE for non-carriers was 5.4%. In heterozygotes, 10.9%, and in homozygotes, the rate was 32.6%. And from a symptomatic point of view, that translated as rates of 1.4, 1.7, and 9.2% respectively. So for the purposes of the Clarity AD lecanemab trial, the mainstay of safety monitoring for both ARIA-E and ARIA-H was asking about adverse events at each fortnightly infusion visit, and then a series of MRI scans to try and pick up any changes. So patients were given MRIs at screening and then at 3, 6, 12 and 18 months. If we think about what the recommendations would hypothetically be if these drugs were licensed here, then there's a pretty good model already from the States based on the protocol. So this is from the appropriate use recommendations from lecanemab, this bit at the bottom. And they have pretty similar requirements to the study itself, but actually there's an extra scan at the beginning, I think. And both in the study and in subsequent recommendations, you also get scans if you have any symptoms suggestive of ARIA. I won't go into the detail of this, but in the study itself, we were guided by pretty detailed algorithms of what to do if a patient either had asymptomatic ARIA that was picked up on a scan, or if they were symptomatic. You can see the guidelines range from you carry on with infusions as normal with mild asymptomatic changes, up to permanent discontinuation of the drug if people had more severe symptoms, or if there were more significant radiological findings, even in asymptomatic patients. And similar with ARIA-H. So again, the algorithms were down to levels of numbers of microhemorrhages seen and what to do after that. So it's probably worth noting at this point that there's been lots of interest and discussion around 3 deaths reported in the open label extension part of Clarity AD associated with cerebral macrohemorrhage. And although these were also associated with anticoagulation treatment and various other medical comorbidities, it certainly generated a lot of interest, as you'd understand. This flowchart's quite nice, I thought, much easier to read than those tables. So the link, I wasn't as organised as some of the previous talks and done QR codes, but this link here should go to the lecanemab appropriate use recommendations from JPAD. And this breaks down to straightforward steps about what to do if a patient has symptomatic or asymptomatic ARIA, and a recommendation for monthly monitoring by MRI until symptoms or radiological findings resolve. And when to restart treatment, when to restart the infusions if that's what patients want, and also at what point to stop treatments completely. So, for example, the green box at the bottom says treatment must stop for good if there are more than 2 episodes of ARIA, or if there are more than 10 microhemorrhages seen on an MRI since treatment began. So I've got a few case studies based on some of my experiences with giving people lecanemab. The first example, this is an 84-year-old woman initially presenting to a memory clinic elsewhere in the trust. She had a 3-year history of short-term memory problems. She was forgetting appointments, needing to write more things down. So she had preserved functioning, and on testing had cognitive test scores of 23 on a MOCA, 24 on an MOC, and her MRI was pretty unremarkable. She was given a label of amnestic MCI in her memory clinic, and as is the way, was discharged to the care of her GP. Her and her husband were interested in research and contacted Mark, and we saw her in our trials unit and enrolled her onto the Clarity AD trial in January 2020. So she's had fortnightly infusions since and was monitored with MRI as per protocol. She then went on to the open label extension of the trial in August 2022. So this is a nice bit of some trial designs where after you do the main placebo control bit, you get the chance to continue on the trial where everyone's given the drug and everyone knows that they're on it. So she's subsequently been unblinded for the main bit of the trial, and we know that she was on placebo for the main bit. In November 2022, after she had a regular safety MRI, she was found to have ARIA-E. She was asymptomatic, but she met the criteria for the infusion to be suspended because her radiological findings were significant enough. I'm not sure how these will come out, but it was quite nice. We got the scan images sent through so we could have a visual representation to help discussions with the patient and her husband. We do our commercial research scans locally at our private Nuffield hospital, really for ease of access. And we got the report back quickly from them with the conclusion that there was new signal change in the frontal and right occipital lobes suggestive of ARIA-E. And then the scans are also read centrally, I think based in the States. And this was labelled as moderate ARIA, I think because of the involvement of more than one site. So she then had a follow-up safety MRI 30 days later, which is part of the protocol, in December 2022. At this point, her ARIA had reduced but not resolved. But she is now noted to have ARIA-H, so microhemorrhages. And although she remained asymptomatic, then in March, still off the drug, she had an episode of fainting in the hairdressers. I think they were washing her hair and she was bent over the sink. She's quite unwell, so ended up going to a GP and then sent off to ED. And I think they ended up labelling it as an episode of postural hypertension, and her blood pressure medication was changed. But we thought that the fact that she'd reported faint and dizziness was probably enough to say that she could have been symptomatic from her ARIA. So she had a further, so she continued off the drug, and then had a further MRI in April, which showed that the ARIA-E had resolved and there was no new ARIA-H and no new symptoms. She was very keen to restart the infusion, so she's continued on them since that time, and she's had no further problems. Just to put it in a bit of context and some, just for interest, her MMSE and ADAS-Cog have shown only a slight deterioration since starting the trial, but her CDR has gone from 0.5 to 1, which does show some deterioration. Next case study, 76-year-old man, 2-year history of problems with remembering names and faces. He was repetitive in conversation, but continued to function well in terms of driving, looking after his grandchildren, managing finances, etc. He was seen in memory clinic, given a label of amnestic MCI and referred to us at Mark because he said he was interested in trials. He met the inclusion criteria for the lecanemab trial, so MMSE was 27, CDR 0.5, and he also demonstrated enough episodic memory problems on the Wechsler paragraph test, and he was amyloid PET positive as demonstrated on his PET scan. So he started lecanemab November 2019, and he's had fortnightly infusions ever since. So he does a 100-mile round trip every fortnight. He brings his bike down and cycles around the paths of the New Forest after he's done his infusion, which I just thought I'd mention just because demonstrating the actual amazing dedication that these patients have shown as part of this trial. He's had lots of MRI scans as per the protocol and has not had any ARIA. He's now on the open label extension, and I know that from the unblinding, that he's been on the study drug throughout, so since November. And again, just for interest and anecdote, his MMSE remains at 26 and his CDR at 0.5 when we did the last big testing visit in October 2023. And I really just put him in as a case study to show that some people can have the drug smoothly without difficulty. Last case study, 61-year-old woman, again with a label of amnestic MCI. She started the study she was my first person back in September 2019. No adverse events through the main bit of the study. And then we gave her started on the open label extension in March 2022. On the first day of the open label extension, I gave her the infusion and she started to feel unwell. She complained of feeling sick. She became drowsy, shaky, and was hypotensive. We ended up giving her some IV hydrocortisone and some chlorphenamine. We monitored her for 4 hours where we do the infusions in the day unit. But as it was getting on towards the evening and we didn't want her to go home on her own, my friendly colleague on MAU gave her some fluid and looked after her overnight, and she returned home the next day. So me and the patient had a discussion and decided together that she wouldn't restart the infusions. So she hasn't returned to the trial, but I phoned her a couple of weeks ago and she's doing very well. So she had an infusion reaction, which was the other fairly common side effect seen in the anti-amyloid drugs. So 26% of people on the lecanemab arm had infusion reactions. Again, this was nicely mapped out for us as the different stages of reactions and what to do. Although obviously it was very scary for both the patients and for the treating team at the time. Probably worth noting that I think largely because of concerns about infusion reactions, one of the logistical issues about giving lecanemab is that after you give the infusion, at least at the beginning, you need to monitor people in clinic for up to 4 hours. which is a lot of waiting around and needs consideration of space and time. In the appropriate use guidelines, the monitoring time comes down quickly after the second and third infusions, but it's still an extra practical layer of thought that's required for how we're actually going to deliver these. So just to end, just thought I'd finish with coming back to our hypothetical situation where a disease-modifying drug has been licensed and we were trying to set up a service to deliver it. So I think we can largely be guided by the trial protocols for what we would need for safety monitoring from a practical point of view. So away from the kind of early diagnosis bits, and amyloid PET scanning or CSF biomarkers or blood biomarkers that we heard about in the previous talk, we'd need a safe space to deliver infusions. I guess I wanted to build on Ross Dunn's lumbar puncture clinic bit here. So my personal view is I don't think that necessarily needs to be run by neurologists in big university hospitals. I think eventually we could certainly do it in little community hospitals around the country like I'm doing at the moment. We'd need lots of imaging capacity to meet the need of all the MRI scans. And on top of the MRI facilities, we need enough people to report the scans, and we need some sort of system to accurately read them, report on the ARIA, and quickly feed back to the treating team before the next infusion is due. So they're quite time limited as far as reading. So in the trials, we have local reads of scans by local local radiologists. Then also a central place, which I thought was in the States, where the images were sent and the presence or absence of ARIA was confirmed. Then we got the go ahead to continue with the next infusion. I've no idea, I haven't given this a huge amount of thought about how feasible this could be, but perhaps there could be a centralized system like we use for clozapine, where the MRIs are read and you get a green, amber or red signal sent to treating teams. In addition, we probably need to talk to patients about considering ApoE genotyping so we can properly inform them about risk profiles for experiencing ARIA, and would need to properly counsel them about that. Again, I haven't thought about this properly and I don't want to do anyone out of a job, but I guess AI might be a consideration for interpreting thousands of MRIs for ARIA. I won't go through this slide in detail, but these are the recommendations from the lecanemab appropriate use recommendations paper that I referenced earlier. And we've covered most of it today, but I would recommend reading the paper for a good overview of what resources required from initial diagnosis to safety monitoring. It purposefully, in the guidelines, doesn't cover a discussion of efficacy or the role of accelerated approval or around insurance in the States, but it does talk about the scope of the evidence. For example, which patient groups were included in the trial, which patients should be excluded based on risk profiles, etc. And I quite like this resource section about what would be required. So that's where I'm going to end. Here's a link to our website at Mark if anyone's interested. Thank you very much for listening, and I will hand back to Ben and Vivek.
Thank you so much, Brady. A really inspirational talk. Absolutely fantastic. I think the key thing here is that you have done this. You've done it outside of an ivory tower, and you've done it successfully. So well done to you. I absolutely take my hat off to you for leading the way and doing that so well. Your reward are some questions in the chat. So let's have a look at some of those. So the one question was, should we be testing for ApoE4 routinely for patients thinking about these going on these drugs? Do you have a view on that, Brady?
So the appropriate use recommendation paper has thought about this issue in the States about how it should be done, and given the significant risk change if you're a homozygote, that they feel that should be offered to everybody. Although they do clarify that by saying that needs to be adequately, people need to be skilled and think about adequate counselling. I can't remember what the words are in describing people the implications of being tested and all that involved. But I think, if we've got the evidence that your risk profile is changed so dramatically by your genotype, then I think we certainly should be considering that.
Yeah, so E4 is about 2% of the population, so that would be that's the sort of numbers that may relatively screen out or perhaps be at higher risk. Though Bob Barbara's put a fantastic comment in the chat describing the sort of dose response relationship between ApoE4 genotype and risk of ARIA. A good question from Marissa Ray. Do patients have to have fortnightly infusions for life, Brady? This might be one for a higher power, but I don't know if you have a view on that for lecanemab.
I don't have a view on that for lecanemab, and I guess that's the point of the open label data. I know with other monoclonal antibodies, doing exactly what Kevin was talking about earlier, is that you dose people until you demonstrate that your ARIA is cleared and then stopped. I can't remember. I think that's from some of the donanemab trials. But yes, I don't think the data is there for lecanemab. And certainly in lecanemab, you continue the way the trials have been run is you continue even once you have cleared the amyloid.
Yeah, absolutely. Elizabeth Linden asks, not all patients with MCI go on to develop dementia. Did they all have amyloid pathology for inclusion in this trial?
They did. For this particular trial, you could either demonstrate the amyloid by PET or by CSF. But again, it's very interesting listening to Professor Bradley's talk about the grey area. And certainly I've had a patient in a trial that have had a negative amyloid PET report, and we pointed out that a year earlier they'd been on a different trial that had given them a positive amyloid PET result without treatment, and the scan was reinterpreted and they became positive. So yeah, I imagine there certainly is some grey areas there. But all of these patients, and in most disease modifying treatment trials at the moment, you do need to demonstrate some kind of amyloid biomarker, whether that's through CSF or through PET.
Yes, thanks. So certainty in medicine is very attractive, isn't it? But it's not always quite how it is. A question has just arrived. There are plenty of others, Brady. Will take us to time. Have you developed a standard operating procedure or any other resources for how you've gone about safely administering treatment that might be useful for others?
We haven't. Our SOPs are based around the trial protocol, so that is the other bit is beyond. We do have individual. It gets very complicated, to the line of the fact that we're making up the drug in a different centre and having to transport it, and that's happening in slightly different ways all around the country. So at the moment, our SOPs are completely based on the trial protocol. Again, I would like to refer you to the appropriate use recommendations, which have a lovely a couple of paragraphs about how to safely give the infusions, but also a lot of detail about what a site should have, including access to intensive care and people with expertise in monitoring. I'm not convinced that that happens for other similar drugs to this, and I know that the talk next week, just to advertise that in advance, is probably about people. I think mentions people's experiencing in giving monoclonal antibodies in other disease areas, and I think we need to take account of that as well.
Yes, thanks, Brady. That's a very strong point. These biologics are used in all sorts of different disease areas and very commonly. So it is not a new technology, and they may be a particular monoclonal, but it's not a new technology in toto that we're grappling with here. I've got to say, thank you very much. We're nearly at time. We've only got 2 minutes, and I do not want to overrun. So I am going to see if I can remember my manners and say thank you. So thank you very much, firstly, to Kitty Kozats, who has organised this and done a fantastic job from the college. So thank you very much indeed to her. Thank you very much to Vivek, my co-chair today. And thank you also to Bob Barber, who behind the scenes has been doing lots of hard work to organise this. These webinars have been very popular. But most importantly, can I say thank you very much to Professor Bradley and Dr. McFarlane for 2 absolutely fantastic talks. I can see all the thank yous coming in the chat, and they're well deserved because they're absolutely timely, and for us as a professional group, incredibly useful to have your expertise and experience, and we're very grateful to you for sharing it with us. So thank you very much indeed.
Thank you.
Thank you.
Thank you very much.